Namaste and greetings. I, Ritika Sundar, a researcher at IMPRI, Impact and Policy Research Institute, Prabhav Evamniti Anusandhan Sansthan, Naya Delhi, warmly welcome you all to IMPRI #Web Policy Talk. Today, we have gathered here for a panel discussion on National Family Health Survey Round 5, 2019 to 2021 under a gender lens. This talk is a part of the series, The State of Gender Equality, #Gender Gaps, which is organized by Gender Impact Study Center. The chair of today's session is Professor Vibhuti Patel, visiting professor, IMPRI, and former professor, Tata Institute of Social Sciences, Mumbai. Ma'am, I request your permission to introduce the speakers.
Please, Ritika, go ahead and introduce the speakers.
Thank you, ma'am. Poonam Muttreja, Executive Director of the Population Foundation of India, has over 40 years experience of being a strong advocate for women's health, reproductive and sexual rights, and rural livelihoods. Welcome, ma'am. Dr. Sayeed Unisa is a professor and head in the Department of Biostatistics and Epidemiology at the International Institute for Population Sciences in Mumbai. She has been working on infertility, gender and nutrition issues, and she has carried out cross-sectional impact evaluation and longitudinal studies in most states with funding of UNICEF, WHO, World Bank, Ford Foundation, and the Government of India. Ravi Duggal is a sociologist trained at the University of Bombay and also holds a postgraduate diploma in business management. He is presently an independent researcher and consultant. He has been involved in many health services, research, advocacy, and training, especially related to health economics, primary healthcare systems, health policy, budgets, decentralization, human rights, right to healthcare, and reproductive health for nearly 4 decades. Finally, Dr. Mala Ramanathan is a professor at the Achyuta Menon Center for Health Science Studies, Thiruvananthapuram. She is a trained statistician, demographer with a PhD from the International Institute for Population Sciences in Mumbai. Welcome, ma'am. We look forward to learning from our eminent panelists, and we look forward to an enriching deliberation. With that, I hand it over to Professor Vibhuti Patel. Welcome, ma'am.
Yeah, good evening, friends. First of all, I would like to offer my heartfelt thanks to Dr. Arjun Kumar, Ritika, and IMPRI team for providing this platform for discussion on such a vital issue as NFHS-5. Whole of India is now academicians and activists and health researchers are debating the findings of NFHS-5. And my co-panelists, Professor Sayeed Unisa, Ms. Poonam Muttreja, Professor Mala Ramanathan, and Ravi Duggal, all of them are experienced and highly erudite and very prolific writers as well as public intellectuals, and we are going to learn a lot from them. We know that the NFHS-5 release recently has come out with several shocking findings, which have been hotly debated throughout the country. This has motivated IMPRI to organize this panel discussion. And we know that NFHS data are highly, they have a high credit value, and they are large-scale multi-round survey conducted in a representative sample of households throughout the country. NFHS-1, which came out with its findings in 93, the survey was conducted in 92-93, and it was the first NFHS survey, collected extensive information on population, health, nutrition, with an emphasis on women and young children. 18 population research centers located in the universities and institutes of national repute assisted International Institute of Population Sciences in all stages of conducting NFHS-1, and all the state level and national level reports for the survey have been published, and the most important thing is that they are in a public domain, easily accessible, easily downloadable. NFHS-2 conducted in 1998-99. It expanded its scope, and it also added features on quality of health, family planning services, domestic violence, reproductive health, cesarean section, incidences of cesarean section, anemia, nutrition of women, and status of women. And the result of survey are currently, they have been published widely. They have been used extensively by the women's rights organizations and the reproductive health researchers. NFHS-3 conducted in 2005 and 6, 2005 to 6, had 18 research organizations, including 5 population research centers, which were involved in carrying out the survey in 29 states of our country. NFHS-4 covered a range of health-related issues, including fertility, infant and child mortality, maternal and child health, perinatal mortality, adolescent reproductive health, high-risk sexual behavior, safe injections, tuberculosis, malaria, non-communicable disease, domestic violence, HIV/AIDS knowledge and attitudes, and the knowledge, attitude, and practice studies they were conducted. NFHS-5 was carried out in 2 phases. First phase from 17 June to 30th January 2020, and phase 2, and it was in the midst of pandemic that these surveys were conducted. And phase 2 was from 2nd January 2020 to 30th April by 17 field agencies, which gathered information of more than 636,699 households, which is a huge sample. More than 7 lakh women were involved, and 10 lakh men were involved. And fact sheets of each state and UT and Union Territory and the District of India is available separately. While NFHS-5 reveals that there are more women than men in India now, women have done well in some parameters such as ownership of bank accounts, mobile phone, voice in the family decision making, fertility rates. The worrying trend that we see is that women have fared poorly in health indicators, and more women are underweight or overweight than male counterparts. Nutrition level is abysmally low so far as women are concerned. Anemia has increased among women and children, and these trends they are revealed by NFHS-5, and they are being debated, especially the question of favorable sex ratio for adult women. This is a highly debated. There are several articles written in newspapers and academic journals, and it is in this context that the 4 experts who are here, they are going to share their knowledge and experience in this domain and insights, and that will be immensely enrich our understanding. So first of all, I would like to ask the Dr. Sayeed Unisa from IIPS. She has been associated with NFHS for a long time. And that how do you interpret these findings that women have outnumbered men? And many have expressed doubt over these findings. And there are states which have also had poor record. There are Gujarat, Maharashtra, Arunachal Pradesh, and there are states, but I think overall sex ratio is shown as a favorable. And the second very important aspect is that what are the factors which are driving this trend? And can you also tell us about the overall findings of NFHS-5, major highlights of NFHS-5? Over to Professor Sayeed.
Thank you, Professor Vibhuti Patel, and all my other panel members. Let me share this screen.
We can see it now. Yeah.
Yeah.
Just one.
Full screen. Okay. Make it full screen, madam.
Good evening, Professor Poonam Muttreja, Dr. Ravi Duggal, Dr. Ramanathan, and the team member of IMPRI, basically Arjun Kumar and Ritika, for inviting me as well as asking me to present the NFHS scenario. Although at present I am not coordinator of NFHS, but my institute do all these surveys, so we are involved in that. And I was coordinator for DLHS for round 3. but I am not coordinator. So this you clear it. But as an institute, all of us are involved in the activities of NFHS, so we are quite familiar with it. As Professor Vibhuti Patel said, that I should give a little overview of NFHS. So just let me show you the primary objective. What was the primary objective when NFHS started in late 80s? The primary objective was to, 1 minute. Yeah. The primary objective of the NFHS was to give essential data on health and family welfare program. This was the first objective of this thing. And with that, it has started. And afterwards, as it has been said by Professor Vibhuti Patel, we have included prevalence of malnutrition, anemia, hypertension, HIV, and high blood glucose levels also. Mainly the purpose when it has been started in the late 80s was that this data set should be used by the health sector to examine ongoing programs as well as setting up benchmark, which program is working, which program is not working, and how to improve. So looking at objective as well as the work, if anybody will see, there is nothing in this objective as well as the in 1980s, any word about gender, okay? So just I wanted to tell you that gender was not the main objective of this survey. Although afterwards, what happened when people started questioning why women are not using family planning, why there is a violence, why this is all those things are there, then gender questions were added in NFHS. And it was to explain about the fertility behavior, to explain about the family planning use, also to explain about ANC care, delivery care, and all those things. It is the byproduct of what was going on, and it has been added as a byproduct of this thing. So if you look at all the rounds, nowhere it is mentioned that we are giving gender variables, but information on gender is also available. What is the main difference between census and NFHS? So this was the confusion people have in their mind. They treat surveys as census. No, it is not. In census, what we do, all of you may be very much familiar with the census and survey difference, but this is for general public who are attending this panel discussion. For them, I want to tell you that there is a method de facto D0 where people are counted at the same place on reference date, and people are also counted on usual residence. So in census, local enumerators collect the data for 3 weeks. It's not just 1 or 2 weeks. Mostly teachers in the locality, in the same locality, and they update the list till the survey census date is completed. They update the list, means birth are also added, death are also added, and they visit several times to the household if information is not complete. And in census, what happened? We are collecting information on household population. We are also collecting information from institutional population. Institutional population means hostels, army people, or hotels, all those people who are living in different college hostels, all the hostels, all the places where people are staying, that information is also collected. So this is an extra thing, institutional population. And also on the last day, houseless population, those who are living on the platforms or those who are living under the bridges and roads, they are also counted. And census is giving information in the form of tables, mostly in the form of table. And these are available till village or ward level. So this is beauty of the census, that it is collected for long period of time and it is covering everybody. Okay. And NFHS have a different methodology. This is a sample-based data, and this is only for households where people are available. So here, D0 method is used only usual residents, and one extra thing is there. visitors are also counted. Okay, and coverage of this thing, NFHS is only household. In institutional population is not there, houseless population is not there. Whereas in SRS, institutional population is also taken into account, basically to get information about deaths. Okay, so in NFHS, only household population is there. And estimates are available till district level now in NFHS-4, NFHS-5, till district level. Previously, it was only for state level. And some of the indicators still are also available only for state level, that is domestic violence, male health. The other beauty of NFHS is that individual level data is available. Anybody can use it, download it, use it, analyze it. So this has freedom to people to analyze in a different manner, but they should understand what is the purpose, at what level I can use this data set, and how I can analyze. Whereas if you go for a single individual level data from census, it will be available, but under different conditions, all those things, and you have to pay for that. Whereas NFHS thing, it is free. So use of NFHS data is much more than census nowadays. Nowadays, it has become much more than census because it is easily available. Anybody can download and use it, raw data. Other one is about, when we talk about sex ratio, you can think about in the first round of NFHS. In the first round of NFHS, sex ratio was given as 944. And at that time in 1991, the sex ratio was 927. 927. It was much higher than what was existing. But at that time, people have not said anything because many of the people who were using NFHS are those who have developed, they were demographers. Nowadays, what happened? NFHS data is in public domain. Journalists are using it. Other researchers are also using it. So different people are interpreting the data in a different manner. So at that time also, it was much higher than the existing census data sex ratio. In NFHS-4 also, it was 991. 991, but was much above than the reported one. And you look at the states where it was above 1,000, it was Bihar, Jharkhand, Chhattisgarh, Orissa, Himachal, Uttarakhand, Kerala, Tamil Nadu, and Andhra Pradesh. In NFHS now, at all India level also, it has crossed 1,000. And these are the states where it has crossed 1,000. And what you can see, because UP also is showing more than 1,000, all India figure had gone up more than 1,000. And if you look at these states, all these states are out-migrating states. And these states are showing above 1,000 this thing. And whereas the state which are in-migrating state, for example, Maharashtra, or you can take Delhi, or you can take Gujarat, Punjab. Punjab also have different type of problems, but all these states are much below 1,000 level. What happened in NFHS, as I have already mentioned to you, that in NFHS, institutional population is not covered. That is primarily males. When you look at army or hostels and all those things, primarily male. The second one is in urban areas, response rate of households is lower than the rural area. And in this state, basically in Delhi, Maharashtra, Gujarat, and all those things, response rate is lower than the other states. And maybe this is because of locked households. And here, when there is a single member, and they will not be able to get data within 3-4 days. So these are also not covered. So these males are also not covered, as well as household population, institutional population is also not there. That's why what we are getting it is very high sex ratio. In favor of females, we are getting. But if you look at the projected population given by Registrar General till 2036, the sex ratio is coming out as 952. Although we do not have census at present, which was supposed to be done by 2021, but because of all these problems, pandemic problems, we have not conducted this. But if you take the projected population, from that also it is coming 952. And most likely that 2051 also women will not outnumber males. So look at this thing out, but this scenario of sex ratio is changing. Why it is changing? It is increasing in favor of females because of lower mortality among females. Female have lower mortality in comparison to male, and the life expectancy difference is coming out as 3 years. 3 years more life expectancy. Previously, women have lower life expectancy than male, but now life expectancy has also increased for females. Apart from this, infant mortality difference between male and female infant mortality is also diminishing. Now it's only 1 point difference, 30 and 31. So on the whole, it is going to increase, but it may not be outnumbered. So it will not be more than 1,000 in any way. And if you look at the sex ratio at birth, that has shown an improvement. However, what happened, this is for 5 years, but this sex ratio at birth is from the 5-year children, means the children who are born from this point to last 5 years. So this gives a average of 5 years. But when you want exactly this enable sex ratio at birth, it will be better to use SRS. SRS people, they never give overall sex ratio, but they give sex ratio at birth. The coverage is good, and they have a dual record system. They visit twice, and they collect from the service provider as well as household service. The next point which I wanted to show you is about the nutrition indicators. So first we have talked about the sex ratio. The second one is nutrition, this thing. What is happening in nutrition when we'll take only BMI? In BMI, there are two components, underweight and overweight. Underweight had slightly decreased, but whereas overweight had increased. The other very striking phenomena is that when you take 15 to 49 female and 15 to 49 males, the anemia level is much higher among female in comparison to male. This is striking, and this requires something more. And not only for 15 to 49, when we take 15 to 19 also age group, which have not undergone pregnancies and all other things, many of them may be unmarried and all those things. But for them also, there is a big difference between male and female, this thing. I have shown this in a graphical manner. Underweight and overweight problem is only 1/3, whereas anemia among 15 to 49, you can take it as a 1/3, and among 15 to 19 as a 1/3. But in this group also, you can see the male area is much less in comparison to females. The main problem area is female, whether you take 15 to 19 or if you take 15 to 19 or 15 to 49. Both the things are big problem. Whereas in overweight or underweight, differences among male and female are negligible, not very significant. Whereas the differences between anemia among male and female are quite significant. And this one is about the education. And this is not from NFHS, but I want to show all of you that the percentage of illiterate people in our population is much higher than what we are talking about. In 20 to 24, you can say more than 30% are illiterate. And they are after 10 years, now they may be 30 to 34 years. You can think about around 40, approaching 40% are illiterate. So in prime age, this many are illiterate. And what will happen to these people? It's 2020, 2001 and 2011. 2011, these people are a little less, but they are going to be illiterate in the future also. this will continue for a long period of time. So what this shows that we are not able to reach out to the female, as well as male also are illiterate. It's not like that only female are illiterate, but male are also illiterate. We need to do something more for them. And when we look at the NFHS data, because within 4 years, the marginal increase have been found for female, and that is good also. We can say that is good. 35.7 to 41% are reported to have 10 and more years of education. And in case of male, it has been found from 47 to 50.2%. So the difference between male and female are still 9% here in education. And women who worked in the last 12 months, it has marginally small increase has been found. And this may be because in IHDS survey, when Professor Sonaldi Desai was talking about it, when you simply ask the question about whether you have worked in 12 months, past 12 months, women may not report, but when you ask whether you have gone and helped your husband in the field, farm or business and all those things, if you ask those women, then they may report that yes, they have worked it out. The other one is about women owning a house and our land alone or jointly. That has increased. This is a happy positive sign, you can say. But most of the time it has been found that parents have to have a big dowry. And this question we need to also ask, further expand it and ask whether they got the property or land from the parents or it is from the husband's side. So unless and until we get this thing from where she is getting it, it will not be very clear. And every married women who have reported the spousal violence, that has slightly decreased, but we need to examine who is reporting spousal violence, whether women are in their houses, when we go and ask them in their own houses, whether who have the courage to report that yes, they are facing spousal violence. That is very important thing, who is reporting and who is not reporting, that has to be examined. And the other one is about the solutions. What solutions we have for spousal violence, domestic violence, we need to think about it. Based on all these few indicators only, I have taken it. So when people start talking about the surveys, and we need to keep in mind there are limitations. We cannot take the survey as a substitute for census. When people want to talk about the sex ratio, they can take projected population sex ratio and show it to you, not the NFHS data sex ratio, because it has limitation for gender related indicators. And overall sex ratio always have to depend from census, because it is covering all male population from different sectors, different places. And sex ratio is sex ratio at birth. Let us try something new also, not necessarily surveys and all those things. Let us see birth registration, hospital data. HMIS is giving only government sector, so we can collect information from birth registration. We can collect data from the hospitals, which monthly or weekly, ask them to display the number of male and female births. So that will be much more accurate than going by the surveys and all those things. What I feel that why so much difference? Maybe because we have behavior-wise differences are there. Maybe male are given much better food, or food diversity is much better in case of males in comparison to females. That's why such a big difference is coming out. So external programs will not help. Here we need to have more counseling, behavior change and all those things, then it will be become. So many people say that girls who drop out from the school because there are no toilets. When we are running Swachh Bharat mission, why can't we do something about school toilets or toilets in the institutions? So there should be some mission to have all the schools girls toilets. And if NGOs or all other sector come out and say that, yes, we want toilets in the schools. So it is possible when we are talking about so many houses have toilets. So why can't we have toilets in the school? The other one is that not necessarily that all the girls will go to graduation, post-graduation, the regular courses. They need vocational courses. And this vocational courses availability should be there in the small towns. What is happening only in the capital city of the state, these courses will be available. And parents do not want to spend so much money on the education of girls, because they say that we also have to invest for or maybe collect the amount for the dowry, how we can spend her on education. So this is one problem with the parents also. Family investment for education of girls is less in comparison to boys. And connectivity and colleges. So many, if you look at many small towns and all those, private sector people are not going, they are not establishing. So at least government or maybe with some incentives, private colleges can be started in this thing. At present, we cannot give employment to all the women, but unless and until we involve in some financial or economic activity, they will not be independent and they will not report the violence. They will not be have autonomy to come out from the house and go to the police station and report the cases. So unless and until they are independent, they will not be able to do anything. So for this purpose, at least involvement of them in the SHGs and the activities related with this SHGs will help them. So we have seen this SHGs involvement in Orissa, Bihar, Chhattisgarh, and women are quite empowered in those places and they are doing a lot of job. So with this, I want to stop it here. Thank you very much.
Professor Sayeed, Unisa, thank you for such a detailed presentation and also explaining the difference between the data from census and survey. And also, we are going to have a last round on way forward, but you have covered that also. And all the processes of NFHS you have explained. Now, I would like to ask another demographer, and especially she's also the alumnus of IIPS and with a technical expertise on NFS, the statistical aspects. So Professor Mala Ramanathan, people also say that more men have died than women under COVID, and there is a whole phenomena of COVID widows. Maharashtra alone has some more than 12,000 COVID widows and COVID orphans. Can that also be one of the reasons for favorable sex ratio of among the adults? The important question that I want to ask you is about the total fertility rate of India has declined from 2.2 in 2015-16 to 2% in period of 2019-21. What are the possible implications for the gendered nature of contraceptive responsibility in this? And second question is that the reports of spousal violence indicate a marginal decline and its prevalence from 31.2% of ever married women aged in the age group of say 18 to 49 to say it is reduced to 29.3% in 2019-21, while the data from the women's organizations and the experiences of state commissions for women and National Commission for Women talks otherwise, that it has increased, the spousal violence has increased. Now, this evidence comes in the context of reports of increased domestic violence during the period from several sources, civil society organizations and the government bodies. Now, is this decline in report of spousal violence reliable? And how do you see this in the context of increase in the indicators of women's empowerment? Yes, Dr. Mala. Yeah.
Thank you, Dr. Vibhuti, and thank you all, Saida, for this very comprehensive detailing of the NFHS, because it's really helps to lay to rest a lot of, what shall I say, sometimes really unnecessary remarks and conjecture involving NFHS and its use, and, you know, going hammer and tongs at things which, in terms of our comparing apples and oranges at times, but, you know, you can shout yourself hoarse, but some people, it's very difficult because, one, as technical experts, we don't really have the exact language in which to start a discourse. And the second part is, to be very honest, some part we get tired and we kind of give up. Both, I think, are in a sense reprehensible and we need to overcome. And I'm so glad that, IIPS has started, because we outside are tired of yelling ourselves hoarse, saying, you can't do this, you can't do that, no, it can't, etc. So, Sayeed, I'm so glad IIPS is coming out in these places and talking in order to, clarify. And that is extremely important step which has happened, I think, thanks to COVID, because it used to be only dissemination workshops. So I'm so happy to see you, Sayeed, explaining with such clarity and so simply. So thank you, because you can see there are 51 people and it's going to be heard by many more. Dr. Vibhuti, coming to the other question on whether the mortality, look, even at the mortality levels, if in the first phase, they could have been far more, so that should have shown up. 14 states are in the second phase. Now, the merged rates are what you're looking at in terms of the sex ratio. So, adult mortality, even after COVID, no matter how high it would have been, given the base population which is involved in this, the, moving of the sex ratio takes huge numbers, because it is like 927 per 1,000. So, moving the census sex ratio or a sample survey which is this large with only male mortality, excess male mortality, which COVID has thrown up, alone may not be the possible reason. The possible reason is coming from these things, that the lack of institutional population in the surveys, and houseless, that is almost entirely male. That could be another reason. The other one could have been the variation that has come due to the migrant nature of people who couldn't move in phase 1 and the people who moved out in phase 2. When you merge these two, also it could have resulted, so that those explanations need to be sought by making a comparative analysis, which only when the data comes out, we will know. But it's a bit premature to, climb up a bandwagon and say sex ratio has declined or increased or anything on the basis of just this data. What we need to use this data is to talk about things like the total fertility rate, talk about its gender implications, which are phenomenal. Huge things, like when you look at you're asking about the gender-based violence and the marginal decline. And Sayeed might throw up a little bit more information on this, but you look at the way data collection happens, in the times when we are not in situations like COVID. Now imagine a household where a woman is sitting in, and probably 9 to 5 kind of data collection timings, unless you get an appointment later. Most of the men are not there. Some women are there. There is reasonable privacy to answer questions. There is a better chance of people answering it, with the open heart. Abhi, in the post-COVID scenario or in the COVID, children, you remember during data collection, the schools were not open. The children would have been milling around. Any number of people would have been milling around. Ha kehne se, it would have been easier to say na and get rid of the whole option. So that is another factor we need to also envisage, the context in which, see, we try for privacy, aim for privacy, but it is very difficult to achieve in reality. You aim for a modicum of privacy, but you cannot prevent people milling around. And that could have also affected reporting in bringing stuff down, because the other evidence, which is through telephone, helplines, other things tells us, it has not come down. So I would, and the other thing is, of all the empowerment indicators, employment has not shown anything more than a marginal increase. And as Dr. Sayeed Unisa herself has pointed out, that is, it may give rise to a backlash, but if it is sufficient sustained period, is likely to marginally bring down and slowly bring it down, which we have seen in our work in rural Tamil Nadu and other places in the past. The initial phase of women stepping out of the threshold is actually not decline, is actually slight increase. And it is subsequent of sustained effort at work that brings it down. So that is one place where I would, reanalyze the data with great care to look at places, and when I interpret, I would look at phase 1 hai, ki phase 2 hai, etc. with great care. But that is not to say that with all, in any survey, we assume errors are random. And the patterns will not be affected. Levels maybe. So I would still accept the patterns that it throws up. But coming to TFR, which is my pet topic, I want to share my screen with all of you. And
Yes, it's on, ma'am.
yeah, so you need to understand that whatever I say here and have said this is a disclaimer I need to say, does not represent those of the institutions I belong. And my 2 PhD students helped me with data compilation here. And it's the decline in TFR has gone from 2.2 to 2. And this falls below the required TFR for the net reproduction rate, which was discussed way back in 1980 population policy, and is still part of the objectives of our current population policy of 2000, where immediate objective of net national population, the unmet needs of contraception, it talks about everything: healthcare infrastructure, health personnel to provide integrated service delivery for basic reproductive and child health care. Medium-term objective is to bring the TFR to replacement levels, that is 2.1, with vigorous implementation of intersectoral operational strategies. Long-term objective is stable population by 2045 at a level consistent with sustainable economic growth, social development, etc. But the target was the TFR, bringing it down with the NRR, that is net reproduction rate of 1. The allied TFR is 2.1. Now we can achieve it with different levels of TFR, but this TFR was the one which we designated. Now look at the declines in the TFR across different places. Almost everywhere the TFR is below the requirement of 2.1 or 2.1 itself, not above. It's only Bihar, Jharkhand, Manipur, Meghalaya, UP that have achieved less a TFR which is higher than 2.1. This is what is represented by the gaps. Otherwise, you can see more or less the red and the blue lines. The blue line comes below because it is a recent TFR. They are almost running parallel. And you can see the red line is above. Very few places do you see high TFRs. Bihar with 3 and I think UP with 2.4. And that itself is a decline if you look at where it was earlier. So, you look at the decline in the total fertility rate. Kerala and Tamil Nadu have actually gone from 1.6 to 1.8 and from 1.8 to 2.4. But you have to remember that it is a historical precedent that exists with demographic transition with very low fertilities. The fertility levels tend to fluctuate year-wise. So that is what this demonstrates. The TFRs of Kerala and Tamil Nadu have been below replacement for close to more than a decade now. The interesting part is the use of modern methods of contraception, even though it's only a 4-year gap. You see a universal rise when you can see everywhere, almost everywhere, that the red line that is the recent NFHS. This is only modern methods. So almost everywhere the red line is above the blue line. Contraceptive use, particularly female sterilization, male sterilization, IUCDs, postpartum and otherwise, condoms, oral pills, and injectables, which are all reported, have gone up over this period. Except few union territories like Mizoram and Chandigarh and Punjab. Barring these, almost everywhere contraceptive use, modern method use has gone. Now, which is a remarkable achievement, finding that the NFHS has thrown up 56.5 is the rate for among women in reproductive ages for all India. However, now this is the gendered comment. If you look at what contraceptives were used and to what extent they were used, please look at how many of you can discern any black component in my bars. I put them as black so as to render them absolutely visible if they exist, and in large parts they are non-existent, and when it exists, it's invisible. A large part of it is the deep blue shade, which is totally female sterilization. And then the gray component is the IUD. The red component is the oral pill. But what is interesting in the recent period is the rise in condom use throughout urban India. Phenomenal increase in condoms usage in urban India. But I'm wary of interpreting it merely as, a contraceptive use. It could be also a disease prevention mechanism. But in order to not to discredit it, men are taking responsibility for disease prevention, if not for pregnancy prevention. So that is taking responsibility in, the number of blue lines, dark blue lines I have is a remarkable characteristic that the NFHS-5 has thrown up, which is to be, we need to enhance this in the coming years through mechanisms to facilitate, more male taking responsibility. If you look at modern methods of contraception, which have gone up everywhere, use of modern methods have also gone up systematically over the 2 periods of time, as I said earlier. Decline in fertility, modern methods. Total fertility rate, then you have, the use of modern methods, which has gone up, contraceptive use. Female responsibility, if you look at, I computed this as, I removed injectables because I didn't have enough states with data for the NFHS score. So I again computed the contraceptives, the rates for female contraception, that is sterilization, oral pills, and IUCDs, to the total use of contraceptives, and computed that as female responsibility for contraception. And what you see is a slight decline. The red lines have gone down. And this I can tell you, because I have looked at it individually as well, is almost totally the contribution of urban condom use. If you see, the red line represents the index of female responsibility for contraception has come down in the recent NFHS. What it means is that men have stepped up and taken some responsibility.
But it can also be that contraceptives were not available during the pandemic of 18.
It could be, but it is condom use has actually gone up systematically over so many states. And that is what is this representing, because, but it is it has increased partly in rural areas and very significantly in urban areas. So and regardless of phase 1, phase 2.
Yeah. Okay. Yeah.
So that is what I think is something which is a bit heartening, but I'm still I would have liked that to have been the contribution of male sterilization as well. But that is something I will come to now in my way. The gendered story of the fertility decline, largely still a woman responsibility. Male responsibility is marginal, but increasing with more men, as I mentioned, using condoms, particularly in urban areas. So rather than, this overwhelming targeting of women for contraceptive use, we need to start focusing programmatic effort. If we have to accept the NFHS and the near universal pattern that is emerging in condom use is telling us that the time is ripe, rather than going back to the same demand side women and targeting women, we need to, women have taken dual responsibility for reproductive work. Biologically, they cannot, stop taking responsibility for childbearing. But the work of stopping childbearing also has to be only women. That is gender. Is because childbearing is biological, why not shift the other part of the work and make it to be shared by men? And they are taking some responsibility. So we need to strengthen that. Because see, if you take, when it came to vaccine for COVID, we all went around asking questions about ki kitne bullets the, like Gabbar Singh, kitne aadmi the nahi puch rahe na, kitne vaccines hai puch rahe the. So why not ask the question, how many doctors are capable of providing vasectomy? What is the facility available for providing vasectomies? How much of effort is going into talking those things? How many condoms are available for distribution in the places? Because unmet need is 9.4 even now. Yeah. Part of it is for spacing, it has come down. So men are taking responsibility. We need to work, staff, promotional efforts, all of that, because policy efforts should enable responsible reproductive work. That reproductive work which is gender balanced and that which enables men to take up contraceptive responsibility as well. And that means also focusing, because there's very little, we've been doing totally demand side work with very minimal work on supply side focus. And we need to start looking at that in terms of training, staffing patterns, not just these sporadic camps for, no scalpel vasectomy, but a concerted, systematic effort which caters to needs if they emerge. And we have to create that felt need as well. And that is because the TFR seems to have has declined. Your demographic nirvana is totally on the bodies of women. So isn't it time men were enabled to, take responsibility, if that is a feature, and that is the gendered story of the TFR.
Thank you, Professor Mala Ramanathan, for giving such a comprehensive and statistically empowered presentation, and also explaining the special circumstances under which data collection was done for NFHS, unpacking NRR1, and also the state-wise differentiation of TFR, and ending with the responsible reproductive work. I think extremely well done, very, very erudite presentation. Now I would like to ask Ms. Poonam Muttreja, that what do you have to say about the NFHS stealing result on spousal violence, wherein a significant number of men and women in 13 out of 18 states have justified wife beating, saying it is all right if a man hits a woman, if, number one, she argues with him, if she goes out of house without telling him, if she neglects the house and or children, if she shows disrespect for in-laws, and if she refuses to have sex with him, if she doesn't cook food properly, and if he suspects her of being unfaithful. How do you interpret this data about spousal violence? Yes.
Ma'am, please unmute yourself, Poonam ma'am.
Thank you, Vibhuti, and thank you to you and IMPRI for inviting me. And these were two great presentations full of rich data and which we can build on. I want to say, Vibhuti, first that I think NFHS has made a huge contribution. I think it was NFHS-3 which introduced the data on violence. And I believe that it not only put violence more strongly on the agenda in the country, but these reasons that you're giving, you know, which NFHS has brought out in 3, 4, and 5. In fact, you know, when you were reading out the list, I was getting very sadly amused, not happily amused, that you can find any reason to beat a woman. So, you know, I can imagine a man listing another 50 points for reasons for violence. And we also, let's not forget, it's not just the men, but even the women, a very, very close number believe that it is legitimate for a man or a partner to beat them under all of those circumstances. So first I want to say is, you know, what it indicates. And the first time when I heard the NFHS data was the first time we knew the large percentage of women who also believe, shocking numbers for men, but equally shocking for women. And my response to that was then, and it is today, that women not only carry the burden of procreation, childcare, family planning, but also maintaining patriarchy. You know, women have been trained, socialized, and our social norms are such that it is women too, it's not just men. And men also, it's part of social norms, all these beliefs. Yes. So that is one. Number two, I do want to say that you have to declare war when there is a situation like this. It's epidemic proportion, the amount of violence that is not only practiced, but legitimized. And by the way, I do want to mention that there is something, I have enormous respect for IIPS, their methodology, data collection. So the comments I'm going to make are not on NFHS and IIPS. My comment is more on women's inability to respond. Like I think you mentioned 9 to 5 is when the survey happens. But at least for the second phase, women were in the house with their perpetrators. How were they going to answer a question? And when we knew at the same time violence was increasing, also through the helplines, not just anecdotal evidence, and NGOs and others who work on these issues, but we knew it will increase, and it was a global phenomena. Why will India stay behind? Patriarchal India will probably be ahead of the rest of the world, where violence increased across the world. So India, there is no reason to believe, especially when women were locked in with their perpetrators and nowhere to go. And men who didn't have access to alcohol, access to going out, stepping out, their frustration came out on the women. And that data is available from helplines. So we cannot trust, we cannot accept this data, and we have to do something to come to a better conclusion and better figures, better numbers, and do something about it. Secondly, you know, as long as public health will not accept violence as a part of their response, violence is going to is something very difficult to deal with, because who in the villages, who are the women who get in, they come into contact with? It's really the public health system, the frontline workers. They don't come into contact with police and others. And many of us have tried very hard, and I think we need to work and campaign, first of all, on do advocacy on violence, a public health response to violence. And that is true for 80 countries across the world. So why not India? And I wrote a paper for the ministry, which I'll share with you all later to take this forward. Second, a third of the ever married women aged between 18 and 49 reported spousal violence, and only 1.5% of women aged between 18 and 29 reported experiencing sexual violence. It's unbelievable, because younger girls experience more sexual violence, unmarried girls, newly married, within the family, outside the family. So there is, we have to find a better way. This is skewed data, and we have to find a better way of doing these surveys, or a different way. And is NFHS the right survey? Though I'm saying I'm very grateful to NFHS for bringing out, for starting collecting data on violence. And this disparity also indicates significant underreporting of sexual violence, not just domestic and other forms of violence against minors as well. The changes reported in NFHS-5 are marginal, and greater efforts are needed to address the social and cultural norms around these issues. And I think this is an opportunity for academics across the country to think about doing surveys, studies, and we also need a large survey. So this is an opportunity, I would like to say, the conundrum and the questions that have come out on this. And my, apart from violence being seen, to be seen as a public health issue or considered a public health issue, this is an area we need huge amount of behavior change communication. And it is I say that with a lot of responsibility, experience, and confidence that it works. Behavior change while communication works. When I say experience, nobody should assume that I'm beaten at home. No way. I'd probably beat up the guy. No, so it's not a personal experience, but my work experience, if I can quickly share with you, we have this serial Main Kuch Bhi Kar Sakti Hoon, which has had 3 seasons and 182 episodes on Doordarshan. And we did external evaluation of each of these seasons, 3 seasons. And in season 1, our baseline showed actually, while NFHS had shown 52% and 54% women and men acknowledging violence, but our survey, our baseline showed 62 and 64%. People indicating that they practice violence and also legitimizing, violence. And in first 52 episodes, we were shocked because 20% less people after 52 episodes, respondents after 52 episodes said they are, violence is wrong, their perception changed, all right, and that it is not legitimate. So I actually didn't believe it. So we called a global expert to India to come, and who's an expert on evaluating behavior change from Texas University, to reassess, to look at our questionnaires, look at our, not our questionnaires, the evaluation questionnaires, look at the data, look at the analysis. And he came back to us after 10 days of he and his team sitting with the experts and the people who had done the evaluation, and came to our office and said, and this was particular data I wanted him to look at. He said to us, stand on the rooftop and say we did it. Then I said, all right, I still didn't feel confident, Vibhuti, saying publicly that we had made such a huge impact. So I looked at data on behavior change communication related to violence for Africa and many other parts of the country, on entertainment, education. And guess what? It was true. And then season 2, I'm not going to share the data with you. I just want to share an anecdote. We read in a small village, district newspaper, that in Bundelkhand, which is, as you all know, is one of the most backward areas. There is a group of men who've started a men's movement. Mala will be very happy, though I'm going to disagree with some of the analysis and positivity Mala brought out about men, but Mala will be very happy to hear what I'm saying about men here. So there's a group of men from one particular village, Chhatarpur village in Bundelkhand, started a movement by taking a pran, as they call it, a vow, that they will not practice any form of violence, sexual, mental, physical, because Main Kuch Bhi Kar Sakti Hu had all aspects of the violence in it, not just physical violence or sexual violence, that they took a pran, they will not do it. And they went around different villages and got men to join the movement, other men. 3 men from Chhatarpur started. And let's go further. They said 2 other things they took a pran on, that they will help the child rearing and they will do vasectomy, and they did do vasectomy. So we read this article and we didn't believe it, quite honestly, Mala. So we sent a team of people, our communication team, to see if this was true. And then we made a film on the men of Chhatarpur, and we had a concert in Bombay where we gave them an award a few years later. So behavior change does work. So I really want to push for behavior change, communication, and finally, we need more data, absolutely, and we need more responses.
Yeah.
And I believe, I want to say here that today, for a woman who experiences violence, it's very difficult to find people for them, homes to send them to. I don't know where our feminist NGOs have gone. There are hardly any NGOs that work on violence against women in terms of not people like us also. I'm not doing anything for women who experience violence, but that's not our role. We never said it was, but the NGOs that worked on it, some have disappeared or ended their work. Is it because there isn't funding? Is it because it's overwhelming? There's too much violence, but there are huge problems we need to deal with.
Yeah. I think we had similar experience even in Mumbai, Dharavi, that behavior change communication. I think, thank you for highlighting that. My second question to you is that, do financial inclusion, having bank account, which has gone up according to NFHS from 53% to 78%, ownership of mobile phones, or women taking part in family decisions imply empowerment? Or is it happening because of certain government initiatives which require women to avail these services for the benefit of household? For example, Jan Dhan account, no, which were opened. Yeah.
So first, I'd like to say, Vibhuti, that all these issues need to be looked at separately. Financial inclusion, ownership of cell phones, etc. Definitely, the government Jan Dhan Yojana may have led to only an increase in the number of women holding bank accounts. I don't believe that's led to any form of financial empowerment, they're not flourishing economically or doing better economically. And it's a feel-good factor for women to have a bank account, I will not deny, and to get some money from the government in the name of our Prime Minister under the Jan Dhan Yojana is a very good political strategy for the ruling party. But for the women, it's if I were to rate on 100, the government gets, or the political leadership gets 100 on 100 for doing this, while women get maybe not more than 5 in 100 benefits. So I want to be very clear on that. Yeah. That's one. Number 2, but I like the idea, and I think we have to welcome the bank accounts being open. We can't just trash it, right? But owning a mobile phone has become today a necessity. And does not necessarily imply empowerment, but we can use it. We can use the fact that women do have telephones and X number of women have to have telephones. We can use that to really reach information, behavior change, communication, and other forms of information. And if we have helplines, whose numbers can be put on the women's phones, we can help, we can going ahead, whether it's government or NGOs or communication people, we can really empower women. It is a tool which can be used to share information, empower women, remind them if they're on a pill that they need to take a pill, or if they are on injectable, we can remind them after 3 months. I can think of 100 ways to empower women using phone. Now, I also want to warn us that there'll be plenty of people, and I'm fed up of all those people who question me, because we use telephone and digital technology a lot to reach young people and women. So people say, oh, but girls have fewer phones than men. It is true. But if you look at the numbers, they are huge in terms of how much impact we can make. Let's not just be frustrated about the fact that there is a digital divide. More boys and men have phones compared to girls and women. But the numbers are huge. Second, I'd like to say, so let's not waste our time only. We must take care of the digital divide, but let's use this as an opportunity that there are a large number of women who have cell phones. Number three, I'd like to say that girls typically, and again, I don't have data. I'm only telling you, since we work with young people, our experiences, girls especially, you share phones. If one girl sees some information, she will share it with other girls. There's much more sharing amongst girls than boys. But amongst the girls too, even phones, girls do manage to take the brother's phone, mother's phone, father's phone in use. So they may not own a phone, but let's not discount the potential of reaching girls using phone. And we do know from research, Shireen's work and other people's work, that girls it is peers. It is their peers, both girls and boys, but much more for girls. Much of the information they receive is from the peers. So just like, in newspapers and magazines, we don't look at how many magazines are sold or how many newspapers are sold. We see readership. Readership can be 100 if it's a library. So similarly, we should try and get a handle and understand how many people use and how many people the information from cell phones use. When we go to villages, we find one girl with a cell phone and 20 girls surrounding. All of us have seen that. So it is an empowerment in itself, I would like to say, but it's not automatic. It's like the demographic dividend. Unless we invest.
NFHS-5 also says decision-making power of women, the percentage of women with it has gone up. So yes, I think that we need to unpack through, some area studies and qualitative research also.
Absolutely. And also, reaching out. See, we know one, and another thing that has happened is, and I think much of the fertility also and women using more contraceptives is to do not so much with what the family planning program has done. It has to do with aspirations of women, and families have changed. And that could also be the reason why there are many reasons. Condoms, if you allow me to speak, condoms have increased. It's not that men have become more responsible, but how can they become more? We say because condom use, they become responsible. Why aren't they being responsible on use of vasectomy? When vasectomy has become so easy, now we have fixed day services for sterilization. They don't even have to go to camps. So therefore, I'm not going to be as kind to men, Mala, as you. And it is a necessity also today for people to have two children or less than two children, because look at the cost food price index. Never mind what they say about inflation, but 5 and 6, but for food inflation, Ravi is a health economist, and he's an economist. He'll be able to tell us better. But I, like a foolish non-economist, might even say it's gone up by hundreds of percent, food prices. People can't afford to feed their children. And then finally, whether it's the men or the women, but primarily the women and girls, their aspirations have totally changed. In fact, I always attribute that to the success of Main Kuch Bhi Kar Sakti Hu and NFHS. The positive things NFHS is showing is not because we've done a lot, invested in women and girls. Yes, education has helped. Literacy is a great contraceptive pill, but much of everything we are discussing has to do with the changing aspirations. And those changing aspirations have come from the exposure girls and women have to communication, not just behavior change communication, but information in general. So the other half, I always say, is know how the better half lives now, and they want to aspire. We have fewer children, we invest in their education, we are investing in girls' education, and so on and so forth. So communication and telephone becomes a very powerful tool, an empowering tool, and going forward, let's plan for that.
Yeah. Thank you, Poonamji, for such an erudite presentation on domestic violence and sharing your ground level experiences. Now it is turn for Ravi Duggal. And how do you view certain encouraging trends such as higher institutional deliveries, decrease in underage marriages, increase of hygienic methods during menstruation period, and some say that changes are marginal and need bigger push for all stakeholders? What do you have to say?
Please unmute yourself.
Yeah.
Ravi sir, please unmute yourself.
Yeah.
Bottom left. Yeah, the mic. Yes.
Sorry. Yeah. Thanks, Vibhuti. What you said, I mean, in terms of the improvements that one sees, I mean, they are marginal. I mean, so there's nothing great to talk about it. NFHS-5 being very different from what we saw in NFHS-4. In fact, if you actually look even further down, you'll see that the improvements from NFHS-3 to 4 are much higher. Yes, it's a 10-year period, but if you factor it in terms of gain in points, I mean, it was much more. And I think there somewhere the credit does go to NRHM, at least where health indicators are concerned. But that apart, I think if we move at this pace in terms of improvement, we're not going to reach anywhere in the SDG targets for most of these health and nutrition indicators. That's very clear. I mean, this pace of improvement, and this doesn't happen because our healthcare system, I want to focus mainly on health, healthcare services and partly nutrition. The kind of healthcare system that we have, at one level, we have a public health system which is very weak, underfunded. We are spending only around 1% of GDP, though the recent national health accounts claim 1.35%, but that's jugglery. And this government is quite very kind of good at doing that. I mean, misrepresenting the trends as they did with the employment figures and so on. So in terms of the improvements that you see in health, I mean, they're not happening the way they should be happening because we have a weak primary healthcare system, both in rural and urban areas. Urban areas are a little better off in terms of at least clinical care, where you have hospitals and dispensaries and more clinical care is available. But rural areas completely lack that, and where the primary healthcare system delivers largely what we call preventive and promotive care, like immunization. And even in immunization, I think there may be improvement over the last round, but we don't really see very, I mean, it's the kind of investment which has gone into immunization, we should, and the kind of technology available, we should be looking at 100% coverage by this time, but we don't see in something like polio, which is such a consistent campaign. You know, on I think one Sunday every month or 2 Sundays every month, whatever. Yet, I mean, we are far below reaching universal immunization for polio. And for the others, less said the better, because the total immunization coverage is very low. I mean, for all the basic vaccines.
Is it worsened during pandemic?
Probably, because if you look at the data, which the HMIS data, of course, the data, there was a lag of availability of data. Data was not available for almost a year the quarterly reports which the HMIS gives. So we really don't know the latter part of 2020 and early 2021. Now some data has come which just show reduced usage of public health services, like even institutional deliveries has gone down, immunization has gone down, access to TB care has gone down. All public programs which are there were impacted drastically, and primarily because the funds of the healthcare system, the existing budget, was being used for managing COVID care. Okay, so no new funds really came in. I mean, with all those PM care stuff, whatever, no real, it was actually just diversion of funds from existing programs. Because people, at least for I think 8 or 9 months, I mean, utilization completely collapsed, not only in the public sector, but for public health services, but even in the private health sector. People were not going to doctors or hospitals because they were wary that they would catch infections and so on. So there was a massive impact in routine kind of, you could say, routine seeking care for routine ailments. So it was clear that now whether NFHS reflects that, because again, it's interesting that you have one round of NFHS in few states, which was during the pandemic. And yeah, so it would be interesting to compare the two sets of states, which one pre-pandemic and one post. I'm sure somebody will do that. I mean, to be frank, I've only looked at the for NFHS-5, the fact sheet for India, and maybe some of the states, but I know certain states, the first phase states, the reports are available, but I was not able to really look at that except a little bit of Maharashtra. So what I'm seeing is more from the fact sheet. Where the gendered aspect is concerned, there's very little in the fact sheet which you can actually look at. So I have actually, what I did was kind of review the NFHS-4 to understand what kind of gendered understanding is emerging from the data that we see in terms of health and nutrition. So yes, for nutrition, definitely there is, in the fact sheet itself, has male-female disaggregation, but to look at more details, so I use the NFHS-4. So what the comments that I'm making are largely based on what I see in NFHS-4, and less of NFHS-5, unless that gender disaggregation is there in the fact sheet. So let's come to now specifics in terms of, say, maternal health or indicators like Vibhuti asked about institutional deliveries. Yes, there is improvement. I mean, and that's been happening maybe because of GISC and other kind of schemes which are there. But that too, one sees that various studies, micro studies, have shown there's a whole lot of fraud also in that. It actually, the money really doesn't reach women. So it's an incentive which has encouraged institutional deliveries. And you see that in the figures, because even if you triangulate with NSSO data, you again see it there. So yes, that's true. But in terms of services that women get, in terms of whether they're getting those benefits which are mandated, that's kind of questionable. In terms of immunization, I've already said not very significant improvement. Similarly, ANC, again, it's okay. I mean, it's just more or less similar. If you factor in that over a 5-year period, you should have had significant changes. Postnatal care is disappointing. I mean, in the sense that it's and that probably explains. I was just looking at some of the mortality, child mortality, infant mortality data. What is very interesting, which I find, is if you look at NFHS-4 data, you find that neonatal mortality, infant mortality, and under 5 mortality favors girls. I mean, maybe the difference is small, but it does favor girls. But interestingly, 0 to 4 years, the child mortality rate and the post-neonatal mortality rate favors boys. So this is something interesting to kind of see why this is happening. I mean, because there are now factors which play out in terms of the patriarchal nature of society, etc., neglect of girl children, etc. Will probably explain that, but this is something interesting to look at. Why is this kind of a gender difference that is there? Whereas the secular rate is in favor of girls, but for these two indicators, why do you see that it is better for boys? So, I mean, one has to deep dive into it. So I really can't explain it at this point of time. But maybe Mala or Sayeed Unisa may have some answers for that. In terms of healthcare, I mean, indicators, I think what I saw very positive in terms of course, this is not there in the NFHS-5 fact sheet about tuberculosis, but I looked at Maharashtra data and it fits the pattern of the NFHS-5. I think if you want to look at a good gendered analysis of a disease, TB in NFHS is very well done. In terms of the kind of the width and the of a gendered analysis, I think it's exceptional. I mean, I found it very interesting. And what you see is between the NHS 3 and 4, there's a huge change in prevalence of tuberculosis, a huge increase for women, and a huge decline for men. I mean, it needs an explanation for that, but it is huge. And for example, if you want the figures, it's from NFHS 3 to 4, the increase for women was 309 per lakh to 389. So that's a pretty large increase. But for men, there was a huge drop from 526 in NFHS 3 to 220 in NFHS 4. Difficult to believe that men have such low level of tuberculosis, especially in rural areas. It's more so in urban areas, there's a decline. I don't know what's the situation in NFHS 5. Maharashtra, I looked at Maharashtra state report, and there you do see a similar pattern, which you see for India in terms of the gender differences in prevalence of TB. The NFHS-5 fact sheet doesn't give the other health data. If you look at, let me go to nutrition. Okay, this is a catastrophic territory. I mean, India's performance on the nutrition front, it's highly debated, and even independent of NFHS, there's enough evidence to show that we are not doing well in terms of nutrition. While NFHS-5 shows a slight improvement, but it's not very significant to anything to talk about. Because if you actually convert them into numbers, what I've done is I've converted the NFHS-5 nutrition data into numbers. For example, if you look at BMI of women, I mean, which is now 18.7% who are below the 18.5 gram BMI, we're talking about 53 million women. So it's a huge number. In terms of numbers, it's huge. For men, it is 46 million men with a BMI of 16.2. So men kind of do a little better than women. But I think it's anemia which is the major catastrophe. I mean, Sayudani already mentioned that women have a much more adverse kind of, almost twice, a little less than twice the difference between the male and female anemia for adults. Which is huge. It is for women it is 52.2, and for men it is 25. So it's a huge difference. And so that speaks volumes, and it points out to somewhere in food intake and availability of other nutrients to women. So clear discrimination is visible in terms of when you look at anemia data. I mean, including for children, but in children the differences for male and female is probably not as sharp as it is for adults. So when you look at anemia, and when you look at the child data on malnutrition, I mean, again, very marginal kind of improvements. In fact, in the case of anemia for adults, it has actually increased between NFHS 4 and 5. I mean, that I forgot to mention. But where children are concerned, I mean, again, the change or the shift from NFHS 4 to 5 is very marginal. But again, we're talking about huge numbers. We're talking about stunted children, about 62 million, wasted children, 34 million, and underweight children, 56 million. Overweight is 6 million. So in terms of numbers, they are huge. And this shows that we have a long way to kind of go in terms of improving nutrition generally, and especially the gender differences which we see, which are quite sharp. So and this despite having ICDS and again ICDS performance. I mean, there are questions on ICDS in NFHS, and you do find that ICDS does not cover. It covers about 56%, I think, of the children who are eligible, as well as women, pregnant and lactating women. Yeah, so so coverage is very poor, and it virtually got decimated during the pandemic. So I'm sure the second round of states will probably show very poor results. I've not looked at that, but yeah. So broadly, this is what were some of the issues that came to mind in terms of looking at NFHS. Though what I would also like to say in terms of the NFHS survey itself, it is a female-oriented survey. I mean, history was RCH. It emerged from the whole RCH program. And it's probably a survey which gives you much more gendered information and data as compared to others. Not that NSS doesn't have that, but NSS reports do not do this kind of gendered analysis which NFHS reports provide. Of course, you can deepen that further because you get access to raw data. But I'm sure NSS also has the same kind of, you can disaggregate everything by gender and do that, but they don't put it in their reports. I mean, their reports are very kind of focused, and they certainly don't have an objective of looking at a gendered analysis, but NFHS does. And I think that is, and somebody's already said that earlier. So that's a brownie point for NFHS. And finally, I don't know whether I should say this later or something. This is in terms of looking ahead, but I might as well do that. I think when we look at it, if you look at the overall kind of indicators which which impact service delivery, it is very clear that there is a lot of inequity. And these inequities are there if you're a woman, if you're Muslim, if you're scheduled tribe, if you're scheduled caste, if you're rural, if you're poor, that is the wealth index that they have, education level, and if you belong to an EAG state, what was erstwhile called Bimaru states. So these are, if you disaggregate data on these health and nutrition indicators, I mean, this is the pattern you see. These are the inequities within the system. And my sense is that these inequities are there because we do not have a strong comprehensive primary healthcare system. If we were spending 2 to 3% of GDP on healthcare, we had all our PHCs and CHCs, all the vacant positions filled up, all kind of consumables, drugs, maintenance done properly. In the other sense that we had an equitable healthcare system, which is universal access, we would definitely see a much better picture and much less inequities that we see today. And then finally, I also kind of, so this is again mostly NFHS-4 based. When I looked at what was the missing gender disaggregation within the NFHS. So like for example, there is postnatal care data, but we don't, it is not disaggregated by sex for newborn postnatal care. Especially if you link it to the post-neonatal mortality, where it is higher for girls. This may be something interesting to look at. Postnatal care for newborn is not disaggregated by sex. Similarly, birth weight is not disaggregated by sex. I didn't find it. ICDS utilization, surprisingly, I mean, the data is there. So that's not disaggregated by sex. Source of healthcare. So what kind of healthcare service do you use? Public or private? Again, not disaggregated by sex. So use of health services. Then even some other broad data, like there are questions about type of employment and continuity of employment. Why do we ask that only for women? Why not for men? And I'm sure these differences can, and there's another set of, I think all the fertility tables, you ask about the women's education, but you don't ask about the husband's education. So I think these are some data which could provide better insights into a gendered understanding. So I'll stop at that. And so if there are any questions or any further questions you have, I could deal with that. Thank you.
Thank you, Ravi, for providing gender analysis of both neonatal mortality, under 5 mortality, and also highlighting the issue of health inequity and how the budgetary allocation is so inadequate and deteriorating healthcare services, and which exacerbates health inequity and need for a gender disaggregated data. I see in the chat box there are no questions, so I request all the panelists to wrap up and have a sum up on the basis of presentations made so far. You have another 2-3 minutes to give a concluding remark and the way ahead. We can start with Professor Sayeed. Yeah.
Just I want to reply to the questions raised by Professor.
Yes, you can do that also. Yeah.
And in under 5 mortality, basically treatment will play a very important role. For male children, they are taken to the hospitals, or bigger hospitals and all those things, whereas in case of female, it is not taken. And just now, Professor Ravi Duggal also said about the birth weight. Yeah. We have analyzed birth weight not only from NFHS, this thing, CNSN data, as well as HMIS data. What we have found, there is a high peak at 2,500 grams, 3,000 weight. So it's not a accurate measurement. So maybe they are filling up the forms with 2,500, so there will not be any problem. So we should use carefully birth weight data. We should not do a lot of analysis on the birth weight. And in the second phase, let me tell you that face-to-face interview is so difficult. It was very difficult. All the protocols were maintained. Everything has been maintained to do the face-to-face survey in NFHS. Not only in NFHS, we have also done in different states on Sabiman also. There was a lot of difficulty in face-to-face surveys, but I appreciate the enumerators who had gone to the field and also collected the data. And when it comes to face-to-face interview, not only for other things, but domestic violence, I am so apprehensive about collecting data in face-to-face interviews in the home about domestic violence. It is very difficult to collect the data. Sometimes it is very easy to get the telephonic call and where women will freely talk about what she is facing it, or maybe helplines where she can report it. But in her own home where all the people are around, If she will say that I am feeling unsafe in my home, suddenly somebody will push her it out, where we will put her. So it's very difficult, very critical to ask the question. Sometimes,
but Professor Unisa, perception, where they said the 7 reasons under which women can be beaten up. Perception is a different and testimony of one's own
there is no
experience
doubt
of
about
violence.
no doubt about perception, because they are not independent. They are not going. There is no other place for them to survive, and they accept it. What they are doing is they are accepting the violence in the form of. I don't have. So we have come across cases where. Do you have any other place to go? We can take you to some other. No. Can you independently survive? No. So what we can do in those situations, we feel very bad. We are helpless. Sometimes we feel very helpless. And the other one about NSV and the male sterilization. NSV have been popularized, but you look at the thing, use of NSV, only it has there in some of the districts where doctors are trained. Otherwise, it is not there. And for male sterilization also, counseling part is very much important. After male sterilization or NSV, those things are missing in our family planning program. If still the apprehension is there about the male, this thing, apart from that, if women get pregnant, what will happen to her? So women said that it is better for me to undergo. Still when you go and talk in focus group discussion and all those things, I will get a lot of blame outside this thing. This was there. And the third point, the last point, which I wanted to tell you, that we are implementing telesubbiman in different states using mobile phone, this thing. So there can be a lot of things can be done by using mobile phones. So at present, it has increased. It is going to be, whenever we talk about consumer goods, so over the period of time, it will increase. So mobile phone usage among girls as well as women has increased, and it can be used in a very good manner. Yeah. We are running nutrition program, intervention nutrition program in the 3 backward states in India, so it can be implemented in other.
Yeah. Thank you, Professor Unisa. Now, Professor Mala Ramanathan, what would you like to say? Your closing remarks, yeah.
Yeah, very quick closing remarks. When I said that male responsibility has increased, you have to look at the figures. You know, there is no state which has female responsibility less than 75%. So the increase is from 75, you know, it starts baseline. So of the total contraceptive use, if you remove in injectables,
yeah,
the maximum contribution comes from female sterilization. Oh. And then you have, you know, a trade-off between IUCD and oral pills in parts. And somewhere condoms are jostling for space in that story. Male sterilization, you know, there was this huge complication of depiction of when the numerator is 1.5 minus 0.5 divided by 0.5 or 0 minus 0 by 0. And if for those of you who don't understand, you're not supposed to do 0 by 0, which means that it was in NFHS-4 0. In NFHS-5 it is 0. So if I divide it by NFHS-4, you can't determine it. And 11 to 12 states were that. Okay. In other places, it is 0.5 minus 0.5 by 0.5. Therefore, numerator is 0, so it is 0. So that is a more valid 0 than the second 0, which I had to do in order to draw the graph. And I have marked that at the bottom. So that is what I meant, because my work in Bihar tells me that there is an, you know, a thoda sa, you know, asha ka kiran, where men are willing to take responsibility. They are running around buying condoms, buying, you know, taking their wives to get the injectable, facilitating that process in a minimalistic way from small scale qualitative studies. So I want that, let us fund this, let us work towards moving in order to enable them to take more responsibility and create an environment where that happens, because I am tired of, you know, this whole TFR story ना सप्लाई की कुछ सोच. Women's aspirations have paved the way for your demographic dividend and the demographic nirvana which we are celebrating. So, you know,
But you have also given the caveat, no, that it is for the concern for health and safety rather than concern for pregnancy that men are using condoms.
Therefore, I feel that we need to start somewhere, and somewhere someone is using a condom. क्यों ना वो इस्तेमाल और वजह के लिए करे. Let us talk, because a lot of, you know, my work in infertility tells me male infertility is equated with impotence.
Yeah.
And sterilization can also fall along somewhere in that, you know, scale. And that is a huge problem. And what Sayeed Unisa is saying is correct. A lot of them also are scared that if I get pregnant, I'll get blamed. Better hai. So wo, you know, choice nahi hai, kurbani hai.
Kurbani, choice. She will be blamed if, yeah.
So, kab tak is my question. तो कभी तो उनको जिम्मेदारियां लेना पड़ेगा और लेने के लिए क्यों ना उनको प्रोत्साहन दें.
Yeah.
That is all I'm trying to say. I'm not saying, you know, men have got hallows.
Okay, thank you. Now, Poonam, your turn.
Thank you.
Please unmute.
Poonam, you're muted. Poonam, you're muted.
So Mala, I'm not disagreeing with you or misinterpreting you. And I see, I mean, you know, we have to welcome the fact that irresponsible men, minus from being minus, are taking a little bit of responsibility. Let's not take it away from them. Having said that, I just feel that sterilization, since it has gone down further, and the fact that sterilization is female is increasing, male sterilization is rigid, and there is this belief and obsession about their libido and their virility, which is interpreted, I know, in the community as, even that is communicated as being impotent. They will weak ho jayenge, ye ho jayenge, wo ho jayenge.
They say khasi karana. Male sterilization, they call it khasi karana.
Exactly. I also know, we also know, and we don't talk about it, and I hope NFHS can include that in the survey next time or the following year. They are scared that if they see, everybody in the village comes to know when anybody sneezes in the house. So sterilization, male or female, to pakka hi pure gaon ko pata hoga. God forbid the woman gets pregnant. We know that there's extramarital sex in our country also, at the village level, at the city level, everywhere. And therefore, there is a fear, because ekdam pagdi utar jayegi. Now, third, so I don't know how we are going to deal with that. That's why I keep, you know, I'm not sure we can do much on vasectomy. But having said that, we must, it's not that we shouldn't, we must invest in counseling, behavior change of both men and women. Even wives don't, as was said earlier, want their husbands to get sterilized. Third, I'd like to say that, you know, men, they can be more responsible in taking their wives' decision-making or their partners, and ensuring that women don't have to go through multiple abortions by temporary methods. There's enough temporary methods. And as far as injectable go, Mala, you know, it's only 1% of the modern methods, temporary methods. It is meaningless at some levels, you know, unless we introduce it properly. We have done, you know, we've just done a tick mark. We've introduced after 30 years, one more method. And, you know, what about implants? You know, we need to introduce temporary methods for the young population, which is at a reproductive age. We cannot my fear is we're going to get complacent at this 2% we've reached. So we don't have to invest much. As it is in the health ministry, there's one technical guy who's responsible for family planning, Dr. Sayeed. The others have all, unhone apna palla jhad liya, and they think it's not a priority. It has to continue to be a priority for young people. not family planning, but access to contraceptives,
Emergency
access to a bigger basket of contraceptives. What is our investment in family planning? 4% of our meager 1.4% of GDP budget is on family planning. Of the 4%, we spend literally only 2% on temporary methods. We spend 80% of it on sterilization, which includes 70% investment in incentives. These are, I mean, I also again hope that the survey can include questions. Those who had tuberculosis or vasectomy, are they doing it for incentives? If men get higher incentive than women do. For vasectomy, the incentive is 200 rupees higher. How is it that people aren't going and doing vasectomy in spite of incentive? So this whole incentives, leave alone disincentives, that this 2-child norm nonsense that we've been hearing, noise that we've been hearing about, NFHS is a very important survey to be taken very seriously. We need to educate our politicians we need a lot more dissemination like you are doing. NFHS, I'm on the board now of IIPS. I keep saying we have to do more dissemination because demographic data is rich in India, but there are more myths and misconceptions around family planning and a whole range of issues. And finally, 2-3 very quick points. Sex education has to be introduced, or family planning education, whatever you want to call it. I am not a diehard fundamentalist who says call it comprehensive sexuality education, but we definitely need that. We need better quality family planning. We need more methods, but along with counseling and management of side effects. Now, these are things they will become an issue only if they're raised, and NFHS is a great place going forward. And nutritional investments, absolutely, we have to crack this. What is happening? This should be worrying everybody and keeping people awake. And finally, I'm repeating, we need to promote a public health response to gender-based violence.
Very excellent. Yeah. Now, Ravi, your turn.
Yeah, I had basically given my closing remarks also, but there are some points I kind of missed out, which I think are relevant with the discussion that is happening. One about just kind of referring to what Sayeed Unisa just said, that treatment is an issue. Because if you look at, for example, the child health, the morbidity data, which is for ARI, diarrhea and fever, you find that the prevalence is less among girls. So probably underreporting is happening.
Possibly,
yeah. But what is interesting is that there's a huge gap in treatment. When it comes to treatment for these diseases, there's a gap. The girls have less access to. Treatment is a critical indicator, and that is linked to how strong your healthcare system is in kind of providing universal access. That was one point. The other point I missed out, which for adult kind of diseases, like again asthma, thyroid, and heart disease, is more common among women than among men, and diabetes is prevalent among men. So that was again a difference. Yeah. And another issue which I missed out was on health insurance, and because there's a huge jump between NFHS 4 and 5 in coverage of health insurance, largely due to the state schemes which are there. But interestingly, I also found out in this is NFHS 4 that where CGHS and state schemes are concerned, there's a slightly higher coverage among women. In sharp contrast to ESIC and private insurance and other. So that's very
Janani Suraksha, is it possible?
No, Janani Suraksha would not be insurance. It will not be part of insurance.
Only the support.
This is insurance like CGHS, ESI. So in ESIC, of course, there's a huge difference because much fewer women work in the organized sector. But interesting for CGHS, which is central government employees, basically you find a higher coverage among women, and similarly in the state schemes which are there. So these were some other findings I thought I would share. Thank you.
Thank you all panelists. You have really provided such an important and like all-round perspective. The gender analysis of demographic data, whether it's a sex ratio, neonatal and under 5 mortality, nutrition data, disease pattern, digital connectivity, domestic violence, conveyed that there are no easy answers. Yes, we have a long way to go. Affirmative action, change in gender norms, behavioral change, communication, and increase in work participation. That's one very important area where whether it's a census or ILO or NFHS, all data show, and even some of the area studies, CMI data, they also give a very, very deplorable picture of women who are out of workforce. The percentage is continuously declining. I think we need a separate panel discussion just on the declining work participation of women. Another very important thing that has emerged out of NFHS-5 is that the question that arises that does the low fertility rate bust the myth of population explosion? It also breaks another perception that Muslims are driving high population growth. Among 5 states with high Muslim population in absolute number and share of population, 2 states, UP and Bihar, have higher fertility rate than national average. However, what distinguishes these 2 states from others like Assam or West Bengal or Maharashtra, Kerala, Jammu, Kashmir is the lower literacy rate among women. So is it not lack of education and not religion which is driving population growth in these states? So I think the developmental investment, education of women also emerges as a very important concern. Visibility of gender in statistics and indicators, and the need for a disaggregated data, the way Ravi elicited that, is extremely important for an action agenda of transformative change in the society. In the absence of census 2021 data due to pandemic, NFHS-5 data gain great importance. We have to for the policy formulations and also allocation of funds, functions and functionaries for program implementation. But the central issue, as Ravi raised it, that universalization of health services becomes a very important concern in current context of pandemic and also the results of NFHS-5. Thank you very much, Professor Unisa, Professor Ramanathan, Professor Ms. Poonam Muttreja, and Mr. Ravi Duggal. Over to IMPRI team. Thank you very much. One second.
Thank you so much, ma'am. And we are way above the time, but very insightful and rich discussion today. And I, on behalf of IMPRI Gender Impact Studies Center, I would like to thank all of you for attending this panel discussion on National Family Health Survey Round 5 under a gender lens. And I would like to thank all of our panelists today, Poonam ma'am, Sayeed ma'am, Ravi sir, and Professor Mala ma'am. And of course, our chair, Professor Vibhuti ma'am, for putting so much of hard work on this very interesting topic today. And we all learned a lot. And thank you to all those who attended here or in Facebook Live or watched later. We do hope that you'll keep on attending our Gender Gaps episodes and our web policy talk. Thank you, everyone. And please take care of yourself. Thank you, everyone. Very nice discussion.
I know, so rich, so much work, homework, each one had done. No?
Everyone, yes.
Thanks a lot. Yeah, bye.
Really.
All our articles actually from everyone.
Yeah, very good.
If you share, we will publish it.
Yeah, all of them are prolific as writer also. So I think all 4 can send the article. And in the journal as well as multiple media, no? Because IMPRI's presence is there in so many forms. Yeah. So
thank you. Thank you, everyone. Have a good night.
Thank you. Thank you.